Hi, my name is Kevin Britton. Today I'll be presenting a clinical vignette titled Groovy Obstruction. For this case, a 58-year-old male presented with past medical history of BPH status post-TURP 1 year prior, heavy alcohol use, and a 30-pack year history of smoking. His chief complaint was worsening abdominal pain with nausea and vomiting. His abdominal pain, nausea, and vomiting all worsened approximately 3 days prior after he had 8 drinks while on vacation. His discomfort worsens with oral intake. He endorses abdominal distension, early satiety, and occasionally emesis with undigested meals from earlier that day. Typically, it is about 2 to 3 hours after he ate that we'd have this episode of emesis. Otherwise, patient does have mid-epigastric pain and rates it as 8 out of 10 pain. He can't tolerate any oral intake because the pain is so severe as well. He also has about a 2.5-year history of chronic abdominal pain. This typical abdominal pain is dull, 3 out of 10 mid-epigastric pain. It usually worsens with alcohol use, and he'll have flares at this time, and it's led to 3 admissions in the past 2 years. Otherwise, each presentation was treated for acute on chronic pancreatitis, and then patient was subsequently discharged. Today, he is tachycardic at 114, respiratory rates increased to 22. Abdominal pain, he has mild epigastric pain with mild distension and normal bowel sounds. Otherwise, for his labs, everything's within normal limits besides his lipase, which is mildly elevated at 72. Given it only being mildly elevated, he also went for a CT scan to require a diagnosis of acute pancreatitis as he did not meet criteria yet. On his imaging, it was found that he had duodenal wall thickening with fat stranding, suspicious for duodenitis, and he also had pancreatic groove and head inflammation as well, and was given a diagnosis of mild acute pancreatitis. With this, they also did know that they could exclude underlying lesion with the duodenitis as well, so they recommended further workup. Looking through his previous imaging, he also had similar findings. 2 years ago, he showed thickening of the duodenum with fat straining that was attributed to duodenitis. There was no call for acute pancreatitis this time as the parenchyma of the pancreas was not inflamed. Second CT scan showed inflammatory staining of the duodenum and pancreatic groove and head consistent with acute on chronic groove pancreatitis is what they called it at this time. In this imaging finding, there shows the edema associated with the pancreatic head that would be seen in the CT scans. Additionally, a diagram is shown to show specifically where the pancreatic groove is right next to the duodenum. So in this case, he was given a diagnosis of acute on chronic groove pancreatitis as well on this visit. The groove pancreatitis symptoms often overlap with chronic and acute pancreatitis symptoms, but specifically obstructive symptoms is more unique to groove pancreatitis. Recognition of symptoms in these imaging findings showing the inflammation of the head, groove, and duodenum are imperative in diagnosis. As we'll discuss further, the underlying workup for possible malignancy is critical in management. In his case, he was given treatment similar to acute on chronic pancreatitis, which is just bowel rest, IV fluids, and pain management. We also strongly encourage alcohol cessation to minimize potential for further flares. With this diagnosis of groove pancreatitis being made, it also merits a further workup with MRCP or ERCP with EUS to evaluate for malignancy. These patients are high risk for malignancy, and it can be the driving cause of these reoccurrence of symptoms, specifically with inflammation in these regions. And it's important to recognize possible pancreatic malignancy as delaying identification can be detrimental in patient outcomes. For his case, he got an MRCP that showed a 0.9 centimeter cystic lesion of pancreatic head. It wasn't worrisome in feature, so 2-year follow-up for MRCP was recommended. So about groove pancreatitis more. Groove pancreatitis is a rare form of pancreatitis, and there's not a whole lot of descriptions in literature about it. Typically, it affects the superior aspect of the pancreatic head, the duodenum, and the common bile duct specifically. Diagnosis is based off of the imaging features. However, definitive diagnosis can be really difficult as you have to rule out underlying malignancy to accomplish a definitive diagnosis of groove pancreatitis. If one cannot definitively diagnose groove pancreatitis from a primary duodenal, ampullary, or pancreatic malignancy, patients are also often forced to have surgery ultimately. Additionally, this patient population that does develop groove pancreatitis is not associated with gallstone or autoimmune pancreatitis. Rather, it's associated with significant alcohol abuse. For groove pancreatitis, acute presentations are treated similar to pancreatitis, and with that, it presents very similar with the severe abdominal pain, nausea, vomiting. In rare cases, there can be gastric outlet obstruction, which we saw in this case. Otherwise, chronic cases can have jaundice and weight loss, secondary to common bile duct changes, And if you try to check for biochemical markers, you may see elevation in bilirubin and alkaline phosphatase, but it's nonspecific, as well as biochemical markers are not useful in these cases either. Treatment is supportive with fasting, fluid, pain management, and alcohol tobacco cessation. Acute interventions are not indicated unless there is some obstruction secondary to the inflammation that would require surgery. And chronically, patients may require surgery as well. The reasons for the surgery would be severe pancreatic insufficiency, weight loss, or intractable pain. Additionally, if you cannot rule out malignancy, typically removing the anatomy is necessary to make sure there is not underlying pancreatic malignancy, which then would require surgery. Additionally, with these patients, surgery has been found to be effective in controlling their symptoms, especially the weight loss and the pain, so it is a viable treatment option and beneficial to the patient, even if it is just groove pancreatitis and not a malignancy. Major learning points from this case essentially is in the acute setting, recognizing diagnostic imaging is critical for groove pancreatitis. If you see pancreatic head, groove, and duodenal inflammation, diagnosis should be made, and suspicion for malignancy should be started just to make sure you're not missing something underlying all of this. To do that, MRCP and ECRP with URS would be required to identify possible malignancy. Additionally, the symptoms in these cases can overlap with regular pancreatitis. However, obstructive symptoms are very unique to groove pancreatitis and are really important to recognize, especially in this case, as it may be an indicator of groove pancreatitis. Lastly, it's ultimately difficult to differentiate malignancy from the chronic changes with groove pancreatitis, and these patients do often have to go classic or pylorus-sparing pancreatitis or a Whipple's procedure, as malignancy can't be ruled out, and in a lot of cases, these patients can have benefit in regards to control